Hi, today we're just going to continue with the upper extremity and get on to the forearm, elbow, and a little bit of the humerus. We're just going to combine this whole PowerPoint into one so you don't have to look for a new PowerPoint next week. Forearm today, with routine views are going to be the AP and lateral. Less common are the obliques for soft tissue injuries. Really for localization of bullets, or if they have something sticking out of their forearm, then it's okay to do a oblique image, but it's not part of the normal series. This talks about a little bit about the anatomy on some of these images coming up. Radius, just the lateral bone of the forearm. Radius, along with the ulna, connects the elbow to the wrist. The radius, just to remember it easily, is that if it's in the anatomic position, it's going to be on the thumb side. So the thumb side, when the palm is out, is going to be your radius. Ulna is the more medial bone, obviously, to go along with that. Runs along with the ulna that connects the elbow to the wrist as well. So the two bones are actually diametrically opposed to each other, so they look similar in size and a little bit in shape, not completely, but a little bit, and they're going to be analogous to each other. When they're facing one direction with the radius, the ulna will face the opposite direction. This just shows a little bit more information on it, talking about a little bit more of the anatomy. This slide here gives you pretty much everything on here that we need to kind of know. We're not going to go over things like the interosseous membrane or some of the nerve passageways on this, but for the purposes of the bones, we're going to look at all of these, and you should know where each one of these are. I'm not going to go through each one of these, but I will say that this is the radius out here. This would be the ulna on the outside. If you look at it, the ulna is going to be slightly longer than the radius, a little bit thicker at the distal end for the radius, and obviously at the proximal end, the ulna is a little bit thicker. This has some basic anatomy on here. The radial head is going to be the very top portion of the radius, or the most proximal portion of that. Common site of injury right through there, as well as the neck, the radial neck. You see a lot of fractures right around this area. Another important part is the radial tuberosity. That's going to be this little bump, and tuberosity is really just representative of a bump or kind of a raised portion of the bone in there. Occasionally you will see fractures on there as well because there's some muscle attachments on that. Styloid process of the radius is going to be kind of the point of that, which goes along with this one. The ulnar point would be the ulnar styloid process. The head of the ulna is going to be at the opposite end, right through here. It's going to be down towards the wrist as opposed to the radial head, which is up towards the elbow. So make sure you know the difference on that. Coronoid process, it's going to be this little kind of point, this little bump that you're going to see here. This is going to be the very end of the kind of the olecranon process. The olecranon process is this whole huge like little area right across in here. And then in 6 here is going to be the trochlear notch. Trochlear just refers to where it connects with into the humerus. AP forearm, so your basic slide here is going to be a 14 by 17 cassette. We're just going to cone it down to about a 7 by 11 side. You don't really need the entire length or the width of the cassette on this. The patient is typically going to be seated in a chair that you can roll around. Affected arm is going to be extended with the palm facing up. Tabletop manual technique, so we're going to continue on with tabletop cassettes. Central ray is going to be perpendicular to the film. That will mean no angle on that. We're going to still use the same 40-inch SID and small focal spot. We're going to center midshaft. There's no real landmark on there, so you really just need to get the joint spaces above and below the forearm. So that means getting the carpal area, but also getting all the way into this. You need to see the not just this joint space here with the radius and humerus attaching, but you need to get the entire olecranon process, which actually goes into this little fossa right in here. Lateral forearm, basically the same. Patient's going to be seated, affected arm on the cassette so that it forms a 90-degree angle with the humerus and hand. So as we get into the elbow, you're going to see the same position for the lateral forearm and lateral elbow. And if you look at it, it's going to be the lateral wrist, lateral hand. It's all pretty much in the same position. Both the humerus and forearm should make contact with the cassette. So very important, you need to make sure that the upper arm here is down flat against the cassette. So you may need to lower the chair, raise the table, add some sponges underneath the cassette, but this does have to be up so that this is level. Tabletop manual technique, again 40 inches. Central ray, there's no angle on that either. I'm just going to center midshaft. You should see a nice open joint space around the olecranon process as we get into the joint space here. As you look down here, you need to see superimposition of the radius and ulna, just like you would see on a lateral wrist or lateral hand. Some basic fractures that you'll see occasionally. You may break one or both bones. So a little oblique fracture here. Looks like both bones are broken in there as well. This is just an external fixator, just kind of get the bones lined up. Green stick fracture. Some of you had that as part of your fracture pathology assignment last week. Just a little bit of a kind of a bending that we're talking about, where one side of the bone is broken, the other side is kind of bent a little bit. You typically see these in children more often than not. Elbow routine views are going to be our AP, lateral, internal, and external oblique. Those are pretty common throughout. Most clinics will use those 4 views for the elbow because there is so much anatomy associated with that. So usually you'll have a 4-view elbow. Alternates, modified AP views that the patient can bend, straighten their arm out. Cross table lateral, tube angled views for trauma. So with this, not all of your patients are going to be able to do the positions that you want, so you're going to have to kind of mix and match your way through this to get the views that we need. This just shows a little bit more of the elbow anatomy. It's just going to articulate, really, the elbow isn't a particular bone, but it's a kind of a crossroads of basically the humerus, the radius, the ulna, and the little fossas that are created in here with the joint spaces. AP elbow, first view here. It's going to be a 10 by 12 cassette. We're going to cone it down about a 4 by 6. May leave it maybe a little bit open top to bottom. Just really depends on how long your patient happens to be. And the width is really going to be the skin line. So you really should be able to get towards the skin line on your elbow views. Patient will be seated again. Affected arm is going to be extended with the palm facing up, just like the AP forearm. Tabletop manual technique again. Central ray perpendicular to the film, so no tube angle. 40-inch SID and center to the elbow joint. So wherever it bends across the elbow is where you're going to center your central ray. Marker should be lateral on this. This looks like a left elbow AP. You can tell that it's AP because there's a slight crossing over of the radial tubercle with the ulna here. You're going to look at the condyles, these little kind of rounded areas on the sides of the bones. Those should be equal in size. If you look in the middle here with the olecranon process going into it, this is the olecranon fossa that it actually sits into. So properly positioned will demonstrate slight superimposition of the radial head and tubercle. So you're going to have a little bit of overlap across the ulna on this particular view if it is done right. Just a little bit more anatomy on here. I'm be responsible for just about all this information, so make sure that you go over it. Internal medial oblique elbow. These are the things, the same thing. This is just internal rotation or a medial oblique elbow. Basically all the same things going all the way down. What we're going to do on this one is that you are going to just turn the hand so that the palm is facing down. So what that does, it gets it into kind of an oblique plane. So now that you can see just one side of the condyle, the epicondyle is right through here. The trochlea is going to come out a little bit more on this internal rotation than an external rotation. And the two bones, if you look at them, are going to kind of cross over. So this is the ulna here, radius here, so it's going to kind of form this little mini kind of X going across on here. Properly positioned, we'll show the oblique elbow with emphasis on the coronoid process. So what we were looking at with this is that we were looking at this little point right through in here because this is a site of quite a few fractures on there. So this is your area of interest on your medial oblique or your internal rotated elbow. Our external or lateral oblique elbow, basically the patient is going to be in an AP position and then they're going to drop their shoulder towards the outside. Same thing going across here. I'm not going to go over it each time. What you're going to do is center in the elbow joint again. What you're going to do is you're going to rotate it out a little bit just to get the radial head, neck, and tubercle out away from the ulna. So just by turning the body a little bit, we can kind of open this space right across here. We're going to get a little bit more of the capitulum going across here now because we're looking at the opposite oblique. This right here is just showing what you should be looking for: radial head and neck free of any superposition. Okay? This is actually a wrong marker, so this is the image found on the web. This would be an actual left elbow, so be diligent about your markers. Lateral elbow, This one's a little bit different than the rest. It's going to be 10 by 12 cone down to about a 5 by 5. Because we are bending the elbow at a right angle, we do not need to have a lengthwise orientation. Now we're going to get equal amounts of the humerus, equal amounts of the forearm, so we can use a square box. Let's see, tabletop manual technique. The main thing is here, arm bent 90 degrees with the hand in a lateral position. So the hand also has to be in a lateral position because that's going to affect the radius a little bit and how that kind of moves around a little. Properly positioned will show equal amounts of the humerus, radius, and ulna. Condyles of the humerus should be superimposed. So the ends of the humerus should look like one bone. If they're away from each other, then you're going to see one round part here, and then you may see another round condyle over here. That would indicate that it have some type of rotation on there. You can sometimes see fat pads along the back on here. You can't see it on this particular patient, but anytime there's any sort of trauma to the elbow, a lot of times blood will fill into that little space along the back portion here where the fat pad is, and then it'll indicate the presence of a fracture. Some other elbow problems, dislocations you see. Because it is a joint space, the condyle can pop out of that joint space occasionally. You can see it pretty well here on this lateral view. This one looks like an AP view. Sometimes a little bit of fracture is involved with that as well. It shows some comminuted fractures, and if some of you had a comminuted fracture, it's just all beat up and splintered across within the bone. You can kind of make out the epicondyle. You can see the capitulum, trochleum on the outside, but you can see that it's all busted up into little pieces. So they're going to have to realign that and probably plate or pin it with some K-wires. This one here has a dislocation associated with some fractures as well. So this part right here is actually supposed to be in this joint space here. The ulna is actually fractured and splintered across on here. Radial head looks a little bit underpenetrated, so it's a little harder to see, but that you could probably infer is also broken. Humerus, routine views are just going to be AP and lateral. No obliques for this, just two views. Alternate view, lateral transthoracic. That's going to be done in cases with trauma where the patient can't move their arm at all. Anatomy-wise, just make sure you get the greater tubercle out here towards the outside. There is a lesser tubercle out here as well. We'll point them out in the lab class on there. Obviously, you need to know all the anatomy down by the distal portion of the humerus as well. AP humerus, 14 by 17. You're going to collimate that down according to your patient size. You're going to use the bucky. You're going to be upright or supine. Most of the time we will do this upright, but you can do them supine if they cannot move around. 40-inch SID, rotate affected arm internally and externally. Depending on where you are, the external rotation is going to give you a true AP position, similar to the anatomic position. Internal is going to give you kind of a lateral position if your clinics choose to show you how to do that. Center about mid-humerus, make sure you include both joints at each end on the same image. So we need to make sure that you see the elbow joint in here, and you see the entire head of the humerus as it articulates with the glenoid fossa. Lateral humerus, basically the same thing, 14 by 17 cassette, still the upright bucky. You're going to bend the affected arm into a lateral position. So if you look at the arm, it should look similar to a lateral elbow down at the bottom. Center mid-humerus again, make sure you include both joints at each end on the same image. There's a few different ways to do the lateral that you would show here. This is the PA kind of lateral position. So patient will have their arm bent. We're going to get them a little bit closer to the bucky. This is how we're going to show it to you in my lab class. Other places, we'll do a lateral position with internal rotation. So they'll do this for the external for an AP, and then this will be the lateral position. I don't favor this one just because it doesn't quite show the elbow joint quite as well, but it does move it into a different position. So depending on who you work with, they may show you one of these two different ways here. Transthoracic lateral humerus, trauma view done in suspected fracture cases. The bad arm is basically going to stay down when a patient can't move around too much. Patient's going to stay in a lateral position. Good arm just goes on top of the head, just like you see here. You're going to shoot through the chest, superimposing the proximal portion over the humerus, over the lungs. So we're really looking just for this right through here. This is going to give us the proximal portion. We're just going to do a cross-table lateral the distal humerus by sliding the cassette basically into their armpit and getting the whole distal side on there. Show some more fractures and dislocations, more fractures. If you have any questions with this, please be sure to ask.